Well, good morning or afternoon, and welcome to the first Best of SWOG for 2024. I want to make sure that we both stay on time and have time for questions for our presenters, so we're going to jump right in. I will remind you to put comments and/or questions in the chat box. So with that, we'll introduce Dr. Michelle Zhang, who will be talking about S1203.
All right. Hi. Thanks, everyone. Thanks for inviting me to speak today. I am a third-year internal medicine resident at the University of Washington. And my slide is titled Obesity and Outcomes in Previously Untreated Younger Patients with AML Enrolled on SWOG 1203. We performed a secondary analysis of a randomized trial looking at standard dose versus higher dose cytarabine with and without varinostat. We presented these findings in abstract form at the 2023 ASH annual meeting, and a manuscript is currently in preparation. Next slide. The prevalence of obesity in the United States has been rising in recent years. More specifically, a paper by Pointner et al. In 2016 had found that the prevalence of obesity in patients with AML increased from 36% in 1997 up to 49% in 2010. The relationship between obesity and outcomes among patients with AML has been inconsistent in prior studies. Most studies have defined obesity as a body mass index or BMI of greater than 30. The WHO defines class 1 obesity as BMI 30 to 50, class 2 obesity as 35 to 40, and class 3 obesity as BMI greater than 40. Our study aims to look at these subsets of BMI more specifically to identify the associations between class 1, 2, and 3 obesity and outcomes in AML. Next slide. Our study examined 729 patients from S1203. 9 were excluded in our study for not receiving protocol therapy or having missing BMI data. Subjects in this study were aged 18 to 60 with no severe comorbidities or cardiac comorbidities, patients with prior chemotherapy or treatment for myelodysplastic syndrome, such as azacitidine, decitabine, lenalidomide, or varinostat were excluded. The subjects were randomized to one of 3 arms. The control arm, DA, was a standard dose cytarabine regimen, also known as 7+3. The second arm, IA, was a higher dose cytarabine regimen. And the final arm was IA with the addition of the histone deacetylase inhibitor varinostat. For reference, S1203 did not find a difference in response rate or overall survival between the standard 7+3 induction protocol and a high-dose cytarabine or high-dose cytarabine and varinostat protocol. Of note, there was a body surface area cap for daunorubicin and idarubicin, as the study was created prior to the 2021 ASCO guideline recommending full weight-based dosing in obese patients. Patients with adverse risk cytogenetics were recommended to receive stem cell transplant in the first complete remission. We used multivariable, time-dependent Cox regression models to assess associations for overall survival. Covariate patterns across BMI categories were evaluated using Fisher's exact tests. Next slide. When looking at patient characteristics in this study, we stratified by BMI category. However, there were only 9 underweight subjects, making it difficult to draw conclusions in this group. The median age ranged from 47 to 51 across the different BMI categories with no significant trend. 83% of subjects in the study were white, and median BMI varied across race subgroups as described on the slide. Of note, we had small numbers of non-white subjects. 7% of subjects were Black, 2% were Asian, and all other races were around 1%, with 5% being unknown. When looking at performance status, 26% of subjects with class 3 obesity had an ECOG score of 2 to 3 versus 7 to 13% of subjects in other groups. There were no significant differences in sex, ethnicity, de novo disease, cytogenetic risk, or treatment arm by BMI category. Next slide. We first examined the rate of early death after induction chemotherapy. Overall, early death rates were low, but patients with class 3 obesity had a significantly higher rate of death compared to patients from other BMI categories. In our cohort, we did not identify differences in the rate of complete remission by BMI category. Next slide. When looking at overall survival, patients with class 3 obesity had a 36% 3-year overall survival as compared to 64% in patients with normal weight. In multivariable analysis, class 3 obesity was significantly associated with worse overall survival compared to normal weight. There was also a trend of increasing hazard ratio from class 1 to class 3 obesity. We adjusted for age, sex, performance status, secondary disease, cytogenetic risk, white versus non-white race, and time-dependent transplant status. Next slide. Next, we looked at overall survival after transplant, as transplant is a very important component of therapies for patients with adverse risk AML. We were also particularly interested in outcomes around transplant in this study, as S1203 included early HLA typing for patients with adverse risk. Overall, we found that class 3 obesity remains significantly associated with worse outcomes after survival. Next slide. Our results suggest that class 3 obesity is associated with worse overall survival outcomes in a large randomized trial of initial chemotherapy for AML, though no difference was identified in the rate of complete remission. There are a few limitations of our study. Given this is a retrospective study, we could not determine the reason why class 3 obesity is associated with worse outcomes. Another limitation is selection bias. Most of our patients were young, and the majority were white with good performance status, so our results should be interpreted with caution in other patient populations. Next slide. While our study could not determine the underlying cause of worse outcomes in patients with class 3 obesity and previously untreated AML, there are a few possibilities. The ASCO 2021 guidelines recommend full weight-based dosing, and it is possible that the BSA cap for anthracyclines in the trial may have impacted outcomes for patients with obesity since these patients were underdosed. Another possibility is that the patients with obesity may have more comorbidities at baseline and may be at increased risk of developing diabetes, cardiovascular comorbidities, and other comorbidities not excluded in the trials, which may have led to complications. Lastly, there is emerging evidence that sarcopenia, defined as loss of skeletal muscle mass and strength, is associated with worse health outcomes, and further research is needed to see if sarcopenic obesity could be contributing to worse outcomes in AML. Identification of this high-risk patient population can help guide future studies, including assessing sarcopenia, identifying comorbidities, and conducting prospective studies in patients with AML and class 3 obesity. Next slide. So thank you to everyone who's involved in the SWOG committee and to my co-authors. I wanted to give a special call out to the people who were instrumental to making this project happen, Megan Othis, Mohammed Soar, and Mary Beth Percival.
Great, thank you so much. While we're waiting for other questions to pour in, do you think the risk, which looked pretty big to me, is sufficiently described now to be incorporated into the decision-making, or does it need to be studied a lot more first?
I think future studies, especially prospective studies and studies looking at comorbidities and sarcopenia, would be really interesting. You know, something that's not really captured well in these patients is if muscle mass is a big component of that, and if we should be screening for patients who are very sarcopenic as well. So I think further studies would be very interesting.
What about out in the clinic?
You know, again, I think this was a limited study in mostly young patients and who were kind of on this protocol arm. So I don't know how it would translate to other patient populations, like older patients or patients on different treatment protocols. So I think, you know, maybe more studies would be better first.
That's a very good and honest answer. You also very nicely detailed future directions. Where do you want to take this in SWOG?
That is a good question. I think after maybe some more retrospective studies are done, looking at some of the components like sarcopenia and identifying more comorbidities, coming up with a prospective study looking at patients with class 3 obesity would be very interesting, I guess, with the eventual goal of looking at early interventions for patients with class 3 obesity, if that is found to be significant, or perhaps patients with increased sarcopenia, et cetera, whatever was identified to be significant in these future studies.
Great. And it looks like my old mentor, Dr. Lowell Anthony, has a question. Do you have data or theory on other malignancies with potentially similar outcomes?
Oh, that's really interesting. Well, at least within kind of more hematologic malignancies, MDS is also associated there's an increased risk of MDS in patients with obesity. And so I would wonder if this may be related to those patients since they have a more similar phenotype to patients with AML. So that could be certainly an interesting future direction.
Fabulous. Okay, it looks like that is it. Again, thank you so much for presenting. We're going to move on to number 2. It's Dr. Rachna Shroff, who's going to be talking about the results of S1815.
Hi there. Good morning or good afternoon to everybody. I'm delighted to be here and to present on behalf of my co-investigators, SWOG 1815, which was reported out at GI ASCO last year. This is a phase 3 randomized trial comparing gemcis and nab-paclitaxel versus the standard of care for biliary tract cancers at the time of gemcitabine and cisplatin. Next slide. So we know the biliary tract cancers are a heterogeneous group of malignancies. They're made up of cholangiocarcinomas and gallbladder cancers, and we are seeing them more and more frequently in this country as well as globally. Gemcitabine and cisplatin-based regimens were the standard of care in advanced disease, but even with the most recent addition of checkpoint inhibitors, including durvalumab and now pembrolizumab, median overall survival in advanced disease is still only around 12 months. There was a single-arm phase 2 study that we conducted of a triplet regimen of nab-paclitaxel, gemcitabine, and cisplatin that showed promising efficacy in 60 patients with an observed median overall survival of 19.2 months in the single-arm study. Next slide. And so from out of that, SWOG 1815 was born. This was the study design. This was for newly diagnosed advanced cholangiocarcinoma and gallbladder cancer patients. They needed to have an adequate performance status in laboratories, and they were randomized in a 2-to-1 fashion to receive the triplet chemotherapy regimen of gemcis nab-paclitaxel, with the dosing as listed there, versus, like I said, at the time, the standard of care of gemcitabine and cisplatin. 441 patients were planned to be enrolled, and patients were restaged every 3 cycles until progression. The primary endpoint of this study was overall survival with a target hazard ratio of 0.7, and of course, key secondary efficacy endpoints of overall response rate, progression-free survival, disease control rate, and of course, safety was noted as well and followed. The study also included archival blood and archival blood and tissue specimens to be banked, as well as prospective blood collection. And I just want to highlight, because this is what I think we are truly proud of, the first patient went into this study in February of 2019, and this study enrolled rapidly. It closed to accrual in literally 2 years with over 440 patients enrolled. Next slide. So as I mentioned, the primary endpoint was overall survival, and we had a target hazard ratio of 0.7 with 90% power and a one-sided alpha of 0.025. We did have pre-specified stratification factors that included disease site, looking specifically at intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, or gallbladder cancer. And we also looked at disease stage, locally advanced versus metastatic, and performance status 0 or 1. Next slide. These are the baseline characteristics of the patients who were enrolled, as I mentioned, in a 2-to-1 fashion for the triplet versus the standard of care. And you will see that the majority of patients had reasonable performance status, and that the 2/3 of the patients had intrahepatic cholangiocarcinomas, which is a little bit different than a lot of the other global studies that are performed, and really kind of speaks to what we see typically more in the United States in terms of more intrahepatic cholangiocarcinomas. Similarly, about 3/4 of patients had metastatic disease at the time of diagnosis versus locally advanced. Next slide. So this was the primary endpoint of overall survival. You will see that the median overall survival of the triplet regimen was 14 months with confidence intervals as listed there, versus 12.7 months in the gemcitabine and cisplatin arm for a p-value of 0.65. Numerically improved, but not statistically significant. Next slide. Similarly, progression-free survival, again, slightly improved at 8.2 months in the triplet regimen versus 6.4 months, but a p-value of 0.43. Next slide. Now, when we looked specifically at survival by disease site, as I mentioned, that was a pre-specified stratification factor. You will note that there was no significant differences between the triplet and the standard of care by disease site. However, there was a trend towards better survival in gallbladder cancer with Gemcis nab-paclitaxel, with a median overall survival of 17 months versus 9.3 months in the Gemcis arm. Again, not statistically powered, and so numbers are really small, but just some interesting trends to note. Similar improvements were seen in progression-free survival in the gallbladder cancer cohort. Next slide. Again, when we look at disease stage as a pre-specified stratification factor, when we looked at overall survival, the median OS in locally advanced patients was 19.2 months versus 13.7 months. Again, small numbers, but that's that green curve that we're seeing on the Kaplan-Meier, which again suggests a slight trend in terms of locally advanced patients. Next slide. PFS by disease stage was similar in the sense that the locally advanced patients had a median progression-free survival of 9.3 months versus 7.6 months in the gemcitabine and cisplatin arm. Next slide. Overall response rates are listed here, and you will see that the overall response rate in the investigational arm of Gemcis nab-paclitaxel was 31% versus 22% in the Gemcis arm, again, not statistically significant, with a disease control rate of 77% versus 69% when looking at GCN versus GC respectively. Next slide. When we again look by disease subtype and disease stage, you will note that the overall response rate in gallbladder cancer in the triplet regimen was 44% versus 22%, but again, only 46 patients evaluable for response. And that is really the most striking difference that you see. Slightly improved overall response in extrahepatic cholangiocarcinomas as well at 34% versus 21%. And in disease stage, you can see the overall responses, again, were relatively similar regardless of locally advanced or metastatic disease. Next slide. When we look at grade 3/4 treatment-related adverse events, you will note that there were more grade 3 adverse events in the Gemcis nab-paclitaxel arm, more specifically in the due to the myelosuppression. So you see anemia, neutropenia, thrombocytopenia kind of standing out. The additional all-grade AEs that were seen in greater than or equal to 25% of patients are listed there. Now, there were some grade 5 events on the triplet regimen. Some of them were thought to be disease-related, including things like sepsis and then cardiac events as such, but they are listed there below. Next slide. So our conclusions were that the addition of nab-paclitaxel to gemcitabine and cisplatin did not improve overall survival in newly diagnosed advanced biliary tract cancer patients. The overall response rate was numerically higher at 31% versus 22%, but this also did not reach statistical significance. And there were more grade 3 to 5 hematologic toxicities throughout the treatment, throughout the Gemcis nab-paclitaxel arm. However, I will point out that the treatment discontinuation rate did not vary significantly between the two arms. Again, admittedly, exploratory analyses with higher ORR and OS in patients with locally advanced disease or gallbladder cancer could suggest potential utility in these settings and should warrant or could warrant further evaluation. And as I mentioned, with the archival tissue that we have in the prospective blood collection, ongoing biomarker analyses could be prudent and helpful in terms of identifying potential subsets of patients who could benefit from the Gemcis nab-paclitaxel approach. Next slide. And this was my conclusion at the time of GI ASCO, and to just acknowledge the incredible village that it took to really bring S1815 from start to finish and to completion and to presentation. Thank you very much.
Thank you very much, and really, really congratulations on that accrual. So those differences, admittedly small number of patients, were huge. Obviously, it would be interesting to study it further, but right now, if you had a patient in clinic or maybe somebody in the neoadjuvant setting, would you just go ahead and do it, or is it too preliminary or too possibly a statistical fluke?
Yeah, I think that's a great question. And I will tell you, just speaking to investigators across the country, there is a fair amount of usage of the triplet still in that neoadjuvant, potentially downstaging space. The phase two had a 20% conversion rate, and it led to what we call the NeoGAP study, which was looking at Gemcis nab-paclitaxel and what was defined as oncologically high risk but resectable cholangiocarcinomas. And it did demonstrate feasibility, and all patients, completed the therapy and made it to surgery. We're still waiting on RFS data on that study. But, I think it is the space in which we really think about it. Again, when you need that response and that potential downstaging or downsizing or cyto, reduction, if you will, because Gemcis, Pembro, Gemcis, Durva response rates are still very in the kind of mid 20% range. So I do think that a lot of people are using that. I will also just add that, again, we did this in what I think is a very clean and correct manner of giving the Gemcis nab-paclitaxel in a day 1, day 8 of a 21-day cycle so that you can adequately, compare apples and apples to Gemcis. Again, when you talk to investigators across the country, what most people recognize in terms of the hematologic toxicities is that giving it every 14 days is better tolerated. So most of the people that I know that are still using it are doing it more on an every 14-day schedule.
Great. And do you have a potential biologic explanation for the differences, either by location or stage?
I think gallbladder cancers, by and large, seem to always have been a little bit historically more responsive to therapy, even to Gemcis. So I don't know if there is a component of that. The extrahepatic cholangiomas also, because they sometimes, especially the distal cholangiomas, behave a little bit similar to pancreas cancer. It's not surprising to me that perhaps they may also benefit a little bit more from the nab-paclitaxel. But I'm really hopeful that some of the planned translational work that we have that's going to be looking not only at just kind of basic NGS and genomic landscape, which we, obviously know is really important in biliary tract cancers, but we're hopeful that that might help us kind of understand if there's something to that question exactly.
Great. And, barring any clear direction from the TM work, where does SWOG want to go in biliary?
I think we are still actively thinking through whether or not there's a role for a perioperative type of study. And, now with the advent of immunotherapy, can we be thinking through chemo plus immunotherapy approaches in a perioperative space for biliary tract cancer? So that's kind of one of the areas that we're really working on in the hepatobiliary subcommittee with some junior investigators. And then, of course, the other big question is with all these targeted therapies, is there a role for targeted therapies in adjuvant or perioperative types of roles? And so there's, I would say collaborations across the NCTN and in partnership with the Cholangiocarcinoma Foundation to think through some of those questions as well.
Fabulous. Well, thanks again for the presentation and congratulations again.
Thank
Our
you.
next speaker was not available today. However, the results of the S1416 trial were so exciting, we asked Dr. Sharma to record. So we will play that now. I guess I'll suggest if you have any questions, email them to me and I'll make sure they get to the investigative team.
On behalf of my co-authors, it is my pleasure to present the results of SWOG 1416, a phase 2 randomized placebo-controlled trial of cisplatin with or without veliparib in metastatic triple-negative breast cancer and/or BRCA mutation-associated breast cancer. In germline BRCA mutation-associated HER2-negative metastatic breast cancer, PARP inhibitor monotherapy significantly improves progression-free survival compared to chemotherapy of physician's choice, and 2 PARP inhibitors are FDA approved for these patients. Recently, a phase 3 trial also shows that addition of PARP inhibitor to platinum taxane chemotherapy improves progression-free survival in patients with germline BRCA-associated metastatic breast cancer. Efficacy of PARP inhibitors beyond germline BRCA has been shown in other cancers like ovarian cancer. In fact, for ovarian cancer, tissue homologous recombination deficiency tests are now clinically available to aid patient selection for PARP inhibitor therapy. A substantial proportion of triple-negative breast cancers show homologous recombination deficiency or BRCA-like phenotype. However, limited PARP inhibitor monotherapy efficacy has been observed in triple-negative breast cancer beyond germline BRCA. Appropriate patient selection and combinatorial approaches with DNA-damaging chemotherapy may be needed to demonstrate activity of PARP inhibitors in germline BRCA wild-type triple-negative breast cancer. Combination of chemotherapy plus PARP inhibitors at adequate dosing of both has been challenging, though, due to myelosuppression. Recent evidence suggests that PARP trapping potency of PARP inhibitors may contribute to bone marrow toxicity. PARP inhibitors with higher trapping potency are noted to have more pronounced bone marrow toxicity. Veliparib is an oral small molecule inhibitor of PARP1 and PARP2 with minimal PARP trapping activity. A phase 1 trial has demonstrated that adequate doses of cisplatin can be delivered safely in combination with a near maximal single-agent dose of veliparib in patients with metastatic triple-negative breast cancer. SWOG 1416 tests whether addition of veliparib to cisplatin is beneficial in BRCA-like germline BRCA-negative triple-negative breast cancer. This is the trial schema. Patients with metastatic TNBC or BRCA-associated HER2-negative breast cancer who had received either 0 or 1 prior cytotoxic chemotherapy for metastatic disease were eligible. Patients were randomized 1-to-1 to receive cisplatin with either veliparib 300 milligrams PO BID or placebo days 1 through 14 in a 21-day cycle. I want to point out that the dose of veliparib used in S1416 is much higher than what was used in the BROCADE-3 and Brightness trials. Primary endpoint of the trial was progression-free survival in 3 pre-specified groups: germline BRCA group, BRCA-like group, and non-BRCA-like group. Secondary endpoints included overall survival and objective response rate. Post-randomization germline testing and tissue BRCA-like biomarker testing was done to assign patients into the pre-specified groups. This testing was done post-randomization to enable immediate start of randomized treatment. First step in this process was central germline BRCA testing. Patients with deleterious BRCA mutations formed the germline BRCA group. Those without germline BRCA mutation underwent further biomarker testing to identify the BRCA-like phenotype group. BRCA-like biomarker assessment included 4 markers: HRD genomic instability score with cutoff 42, somatic BRCA1 or 2 mutation, BRCA1 promoter methylation, and germline homologous recombination repair gene mutations excluding BRCA1 and 2. Primary tumor tissue was utilized for the 3 tissue-based biomarkers, and positivity on any one of the 4 markers placed a patient in the BRCA-like group. These are key inclusion and exclusion criteria. There was no minimal time requirement from end of neo or adjuvant chemotherapy and study entry. Here are brief details on the 4 BRCA-like biomarkers. Only one of 4 markers had to be positive for a patient to be assigned to the BRCA-like group, but all 4 markers had to be negative for a patient to be assigned to non-BRCA-like group. Statistical plan for the study is summarized on this slide. As stated previously, primary endpoint for the trial was progression-free survival in the pre-specified groups. A hazard ratio of 0.57 favoring veliparib arm was assumed for both germline BRCA and BRCA-like groups. A smaller sample size and higher alpha was set for germline BRCA groups since PARP inhibitor efficacy in germline BRCA carriers was already being addressed in several ongoing phase 3 trials at the time of design of S1416. For the BRCA-like group, the study had 80% power with one-sided alpha of 0.05, requiring a sample size of 86 randomized patients. No effect of veliparib was expected in non-BRCA-like group. Initial sample size was based on assumption that all randomized patients could be assigned to one of the 3 pre-specified groups upon analysis of germline DNA and primary tumor tissue. However, during the course of the trial, some randomized patients could not be assigned a specific group due to sample submission non-adherence or assay failure. Thus, trial sample size was adjusted to 324 patients to ensure adequate numbers in groups of interest. 335 patients were registered between 2016 and 2019, and 321 are included in the intention to treat analysis. Baseline patient characteristics are summarized on this slide and are well balanced between veliparib and placebo arms. 70% of patients had not received any prior chemotherapy for metastatic disease, 10% had neo or adjuvant carboplatin exposure, and a very small minority had received checkpoint inhibitor therapy. The flow diagram on this slide describes distribution of patients in the 3 groups. Blood for germline testing was not submitted for 27 of 321 patients. Out of 294 patients for whom germline testing was done, 37 or 13% had deleterious BRCA mutation. With 37 randomized patients, the germline BRCA group reached only 59% of initially planned accrual. Among those without germline BRCA mutation, BRCA-like biomarker assessment could not be done for some due to lack of tissue submission or assay failure. Among 209 patients for whom this assessment was performed, 99 or 47% had BRCA-like phenotype and 53% were non-BRCA-like. These proportions are in line with the original trial assumptions, where BRCA-like phenotype was expected in about 50% of germline BRCA wild-type patients. The pie chart here shows distribution of individual qualifying biomarkers for the 99 patients in the BRCA-like group. Due to lack of sample submission or assay failure, we also have an unclassified group of 75 patients. Now the study results, which I will present for each group separately. In the germline BRCA group, even though the hazard ratio favored veliparib arm, there was no difference in median progression-free survival between the two arms. PFS of 6.4 months in the placebo arm is in line with what was noted with platinum monotherapy for BRCA carriers in triple-negative TNT trial. There was no difference in overall survival between the veliparib and placebo arms. Moving on to the BRCA-like group. In the BRCA-like group, progression-free survival was significantly prolonged with veliparib compared to placebo. Median progression-free survival was 5.9 months in veliparib arm compared to 4.2 months in the placebo arm, with a hazard ratio of 0.53 and a p-value of 0.006. Objective response rate was numerically higher in the veliparib arm compared to placebo, but this difference was not statistically significant. There was a 2-month numeric overall survival improvement in the veliparib arm compared to placebo, with a hazard ratio of 0.6 and a borderline p-value of 0.067. In the non-BRCA-like group and in the unclassified groups, there was no improvement in progression-free survival with the addition of veliparib to cisplatin. This forest plot demonstrates that in BRCA-like group, benefit of veliparib was similar for all subgroups. Here we also present exploratory efficacy analysis in first-line patients within the BRCA-like group. PFS was significantly prolonged in veliparib arm compared to placebo. 12-month PFS was 23% in veliparib arm compared to 3% in the placebo arm. Similar to PFS, overall survival was also significantly prolonged in veliparib arm compared to placebo, with 2-year overall survival of 43% in veliparib arm compared to 20% in the placebo arm. One of the translational sub-aims of the study was to evaluate the impact of HRD score independent of other 3 BRCA-like markers on efficacy of veliparib. This analysis includes 75 patients who were assigned BRCA-like group based solely on the HRD score of greater than or equal to 42. As you can see, PFS was significantly higher in the veliparib arm compared to placebo. Note that the hazard ratio using HRD score as the sole BRCA-like criteria is 0.53, which is similar to the overall PFS hazard ratio in the BRCA-like group. Moving on to safety, the table describes key treatment-related toxicities. Compared to placebo, veliparib arm was associated with higher grade 3 and 4 hematological toxicities. There were 2 treatment-related deaths, 1 on each arm. In conclusion, for patients with germline BRCA-negative metastatic triple-negative breast cancer with BRCA-like phenotype, veliparib, when added to cisplatin, significantly improves progression-free survival by 47% and shows a trend towards improvement in overall survival. Consistent with the original trial hypothesis, addition of veliparib to cisplatin was not beneficial in patients with non-BRCA-like phenotype. In this study, addition of veliparib to cisplatin did not improve outcomes in patients with germline BRCA mutation. However, with only 37 randomized patients in this group was very underpowered. FDA approval of PARP inhibitors for treatment of germline BRCA-associated metastatic breast cancer during the course of this trial impacted approval to this group. Furthermore, the question of veliparib efficacy when added to platinum-based chemotherapy in germline BRCA-associated metastatic breast cancer has already been addressed by the recently reported phase 3 Blanke trial, which shows improvement in PFS with the addition of veliparib to platinum-based chemotherapy. Toxicity of veliparib plus cisplatin was manageable and no new toxicity signals were noted. Approximately half of germline BRCA-negative triple-negative breast cancer patients demonstrated BRCA-like phenotype. Among the 4 markers used in our study, HRD score contributed the most to BRCA-like phenotype selection. Several translational studies on S1416 biospecimens are planned, including assessment of tumor PD-L1 status, somatic mutations in homologous recombination genes, NPI3 kinase pathway genes, and liquid biopsy and metastatic tissue sample analysis. With demonstration of efficacy in biomarker-selected BRCA-like phenotype TNBC, S1416 results are a very positive step towards expanding role of PARP inhibitors beyond germline BRCA in breast cancer. Combination of veliparib plus cisplatin warrants further evaluation in larger randomized trials for patients with BRCA-like phenotype TNBC. I would like to thank all the patients who participated in the trial and acknowledge funding from NCI, the Hope Foundation, and industry partners. The trial would not have been possible without support from patient advocates, collaborating groups, and healthcare providers at all the participating sites. Thank you.
All right, we're going to jump right into our next presentation. Dr. Riha Vaidya is going to tell us, in what was one of the most interesting analyses done by SWOG recently, just how representative lung map has been.
Thank you, Dr. Blanke, and good afternoon or good morning to everyone. I'm Riha Vaidya. I am a health economist and a statistician at the SWOG SDMC at Fred Hutch, and I'm glad to be here to talk about our work looking at representativeness of patients enrolled in lung map. Next slide, please. Yep. So this work was presented originally at the ASCO annual meeting in 2022 and was published last year in JCO Precision Oncology. And I would like to begin by acknowledging and thanking all of my co-authors whose contributions to this work were incredibly important. Next slide, please. So LungMap is a biomarker-driven master protocol which tests multiple therapies, targeted therapies that are matched to biomarkers under a single clinical trial infrastructure. LungMap is also the first protocol conducted within the NCTN as a public-private partnership. So given the setting of an umbrella trial design and this public-private partnership model, there was little information about whether it improves access to clinical trials for patients. So our primary goal here was to compare LungMap participants to participants in conventional standalone non-small cell lung cancer trials conducted by SWOG to see how patient demographics and other characteristics compare. Secondarily, we also wanted to compare the demographics of LungMap participants with the U.S. advanced non-small cell lung cancer population to examine representativeness. Next slide. So what was our rationale for doing this analysis here? So primarily because, like I mentioned, there is so little information about the performance of this biomarker-driven master protocol approach with respect to diversity of patient populations. We just wanted to assess the performance of LungMap. And second, and very importantly, the generalizability of the findings from any study to the patient population where the therapies will be used depends heavily on the proportionate representation of all the different patient groups. So we wanted to examine that in LungMap and think about generalizability of study findings down the road. And finally, this was also a way to identify areas of improvement with respect to patient diversity for future studies. Next slide. So for the data used in this analysis, we combined SWOG data with data available through the SEER registry. So from SWOG, for LungMap data, we looked at patients who were enrolled to either the S1400 study ID or the LungMap study ID. So these are all LungMap enrollments. And we looked at the period from 2014 to 2020. We also looked at patients who were enrolled to advanced non-small cell lung cancer trials that were conducted by SWOG between 2001 and 2020. The reason for looking at a longer time period for the non-LungMap studies was to ensure that we had an adequate sample size for comparison. For both sets of patients, we used data from registration forms. So this included demographics, age, sex, race, and ethnicity, the type of insurance that patients used, and their zip code. And the zip code was mapped to both rural-urban codes to determine whether patients lived in rural or urban areas, and to the area deprivation index to measure neighborhood level socioeconomic deprivation. The next data set we used was SEER. So we used incidence data from the SEER Research Plus 18 registries. We looked at the time period that most closely aligned with lung map and where data was available at the time we were doing the analysis. We included cases for patients aged 18 years and older who had advanced non-small cell lung cancer. Next slide. So for our analysis, what we first did was conducted a population-based weighting of the SEER incidence rate. So because the SEER registries don't cover all of the United States and they cover specific areas, we wanted to make sure that the demographic proportions we were using were representative for the US as a whole. So we conducted that reweighting. Then for the comparison of lung map with SWOG lung cancer trials, we used chi-square tests to compare proportions by demographic characteristics as well as other socioeconomic characteristics. And finally, for the comparison of lung map to the US non-small cell lung cancer population, we used one sample binomial tests. Next slide. So here's a snapshot of results for the demographics, looking at all of the three groups that we compared. So looking first in the left-hand corner at age. So LungMap enrolled a greater proportion of patients who were aged 65 years and older compared to other SWOG lung cancer trials. But older patients were still underrepresented relative to the US lung cancer population, which echoes results that are found in most other studies where older patients tend to be underrepresented in clinical trials. And the next is looking at female participants, and LungMap did enroll proportionally fewer female participants. And as to the reasons for that, I'll get into that in a couple slides. And finally, looking at racial and ethnic minorities, LungMap participants, the proportion of LungMap participants who were in any racial or ethnic minority group were smaller than other lung cancer trials, as well as the US lung cancer population. For the comparison with other SWOG trials, this seems to be primarily driven by the Asian Pacific Islander patient population, as well as Hispanic patients. While when looking at the comparison to the US lung cancer population, Black patients were also underrepresented. Next slide. And this looks at some of the geographic and socioeconomic characteristics of patients in LungMap and in other SWOG lung cancer studies. So rural patients were proportionately, LungMap enrolled proportionately more of rural patients, as well as patients who were from areas of higher socioeconomic deprivation. So to just quickly explain what that is, we use the Area Deprivation Index, which measures neighborhood level socioeconomic deprivation across various domains such as income, employment, housing. And a higher ADI score basically shows that the neighborhood is more deprived and has more socioeconomic needs. So we just divided scores into quintiles, and we looked at the top two quintiles, 4 and 5, which are the areas of the highest socioeconomic deprivation. And we found that LungMap enrolled proportionately more patients from those areas. And then finally, with respect to insurance, we examined patients who were aged 65 years or younger, because patients older than 65 are uniformly eligible for Medicare. So excluding that population, we found that LungMap enrolled a larger proportion of patients who were using Medicaid or no insurance. Because eligibility for Medicaid or the lack of health insurance is closely tied to a patient's income level, and we don't have direct data on income, this is also a proxy for like household income level or socioeconomic status. And we found that LungMap enrolled a larger proportion of patients who had more socioeconomic needs. Next slide. So to summarize the findings, I'll talk first a little bit about some of the results. So with respect to underrepresentation of female participants, so the S1400 portion of LungMap only included patients with squamous histology, and squamous histology tends to be more prevalent in male patients with non-small cell lung cancer. So the LungMap study ID, which began enrolling in early 2019 enrolled patients of with non-squamous histology as well. So when we broke that data down by S1400 versus lung map, and also looked at SEER data for histology, how histology manifests by patient sex, we think that the driving factor for underrepresentation of female patients is the inclusion of patients with squamous histology only for the first several years of lung map. With respect to underrepresentation of Asian and Hispanic patients, so LungMap did have some eligibility criteria related to tumor mutations, such as patients with EGFR mutations were excluded from participation in LungMap, and literature shows that mutation tends to be more prevalent in Asian and Hispanic patients. So that may have been one of the factors driving this underrepresentation. There may also be other potential patient level barriers which need to be further examined. And in terms of the improved access for rural as well as socioeconomically vulnerable patients, so there are some factors that could have driven this. It includes availability of LungMap at many sites, the outreach that was conducted, the flexibilities that were written into the protocol. So those may be some drivers. And then there were also national policy changes like the ACA Medicaid expansion, which may have increased the proportion of patients with Medicaid. So overall, in summary, master protocols that are conducted as a public-private partnership can improve trial access for several groups of patients, including older and socioeconomically vulnerable patients. But we do need further work to determine why we're still lagging behind with respect to representation of other patient groups. I'd like to conclude by thanking all of our sites and patients who make this research possible. Thank you.
Fabulous, and thank you so much. So let me ask, in the editorial accompanying your recent publication, the editor said health equity is jeopardized by exclusion of underrepresented groups in research. Do we need to formalize inclusion? Should we ask at triage what the diversity plan is on every single study we do?
I think that would definitely help to some extent in sort of figuring out if we're reaching all of the patient population that needs to be reached. I think that also ties in with some of the FDA guidance that has come out in recent times, asking specifically for industry trials, but really it applies to everyone to have a diversity and inclusion plan to see how different underrepresented groups are going to be enrolled in the study.
Fabulous, thank you. And I don't see anything else in chat, so thanks one more time. I'll introduce our final speaker. Dr. Robert Krouse is going to be talking about a true success story for his committee, the Palliative and End-of-Life Care Committee, as well as our Latin America initiative. He'll be discussing S1316. Dr. Krouse?
All right, thank you. And I'm sorry I can't turn on my video for some reason, so I apologize for that. Can we go back to the first slide? So I'll be talking about S1316, as said, surgery versus non-surgery for malignant bowel obstruction. And I apologize, I forgot to put in a disclosure slide, which I have none, but I also should acknowledge that this was funded by HRQ as well as the NCI through SWOG. All right, next slide. So in brief background, for patients, for surgeons, this is a very common issue that we sometimes face. Dr. Badgewell published extensively at MD Anderson showing that over 40% of their consults were for a malignant bowel obstruction, and a high percentage of these were for a malignant small bowel obstructions, which our study focused on. And as you can see, for patients who are consulted by a surgical team, only about a quarter ultimately got an operation. About a quarter got an endoscopic or other interventional radiology procedure, and about half got a non-operative. So it became clear, and there's a whole literature related to malignant bowel obstruction, but there's really no defined algorithm for care for most patients with malignant bowel obstruction. Those that are potentially surgical candidates, not people who are not surgical candidates, and whether the question is whether are we better getting an operation or medical care. Next slide. So I'm going to talk about our manuscript that was published in Lancet Gastroenterology and Hepatology this past summer. And you can see there's a large number of authors, as a lot of SWOG studies are, a lot of very major site lead accruers, as well as a list of team that were part of this study. Dr. Garnet Anderson, the second author there, she was the co-investigator on the grant that made one small change that led to it being funded and ultimately completed. Can you, the next slide, please? So I know this is maybe a little hard to read. This is the consort diagram from the manuscript. Maybe a schema would have been a little bit easier, but what Dr. Anderson did was she added what we had originally designed, or was a fully observational study to a randomized component. Now, for every patient to be admitted or accrued to the study, they had to be surgically eligible. Surgical team had to feel that they were eligible for an operation. And there had to be equipoise, that one was not necessary. Everyone has a bias, but was it reasonable that they would do, you really didn't know whether they do better with an operation or not. Now, as you can see from the consort, now the original, we had, well, it was 55 patients in 165. We over accrued by one, ultimately. For 55 into the randomized arm and 165 into the patient choice arm. And you can see that, for the various reasons, some patients were excluded. The most common was, this was focused on small bowel obstruction, and there were some people who were admitted with a large bowel obstruction. Occasionally, based on our criteria for admission, most importantly, that you can have a documented radiological bowel obstruction. For some patients, we just couldn't find evidence in what was sent to us, so they were excluded for final analysis. And so we, in the very bottom row, you can see we had 24 and 25 in the two randomized arms, and then 92 in the randomized or non-randomized medical arm, and 58 in the randomized, non-randomized surgical arm. All right, next slide. And in fact, we did accrue more into the observational arm, although, you know, we made the definitive criteria that they all had to be eligible and by being surgical and equipoise, although there always is some bias. And so that may have led to some inequality of the arms. But ultimately, as you can see, the age across all the arms was the same. The gender was very similar. Race, we did quite well in recruiting for African Americans. Our ethnicity, we had a high number of Hispanics, especially in the randomized arm, and that had to do a lot with our accrual in Latin American countries, which was sort of a tour de force to get them on board, but it was a tremendous help to completing the study. And one of the differences we did see is the physician specialty, the gynecologic oncologist, maybe a higher percentage of them accrued to the observational medical arm. Next slide. So as far as treatments, this was a pragmatic trial, so you can see that in the surgery treatment, that in the non-surgical arms, there was still some patients who underwent operations, meaning if they had they were treated medically, they didn't get better, or something changed, and they needed to go to the operating room. So you can see that happened. And as you can see also that some patients in the surgery arms didn't actually get an operation, That sometimes may have happened if they were on the surgery arm. They were the next day, maybe they got a little bit better or something changed. And so they ultimately did not get an operation. That was a small percentage, but it certainly happened. Brief word about somatostatin use, octreotide being the most common. You can see that that was much more common in the randomized medical arm, about 40%. We had originally made that a mandatory criteria, but it became far too difficult for a couple reasons. One is that there was a national shortage, and then also the Latin American countries couldn't be on if that was a mandate. So we made it recommended but not mandatory. Steroid use more common in the medical arms as expected, as were PEG tubes, although not that common, but were more common in the medical arms. Next. So this is our primary outcome measure, was good days out of the hospital and alive. And we did not see a difference between whether a surgical arm or non-surgical arm. And we looked at this from the randomized and the patient choice or observational arms. You can see here that if you look at the first two lines of the randomized, second two are patient choice, there's really no difference. There's a little longer days, good days for those that were in the observational arm, which is a little hard to explain. If I would think about bias, I would make the guess that that would be in the randomized study, because maybe I would err towards patients that I thought were a little more well, but it's hard to exactly. We tried to think about why this may be. Ultimately, both arms are the same, though. Next slide. Days in hospital over from time of registration, a little over 12 in the randomized arm, and you can see the observation medical arm is significantly less, but when combining, etc., it doesn't overall show a difference. Days with NG tube use, that's a major outcome measure if you look in the literature for a lot of for outcomes with patients with malignant bowel obstruction, and no real difference could be seen between any arm. Next. Here's where we did see some differences. And basically, we looked at some quality of life specific, MBO specific outcomes: nausea, vomiting, bloating, pain, constipation. And we did start to see that there seemed to be an advantage to the patients who underwent an early operation. And so you can see in the far right, the adjusted combined comparison, that there does seem to be a statistically significant benefit for those that underwent an operation. We also, overall ability to eat does not seem to be different whether an operation or not. Next. So in conclusions, there really is no evidence in our study that surgery or non-surgical interventions are superior in good days alive and out of the hospital. But there does seem to be evidence that malignant bowel obstruction specific outcomes are superior for the early surgery arms. And so that really does have potential impact for those facing this problem and the decision making. So when presenting this to patients and families, while most people don't want an operation, if one can say there's likely a benefit to have an early operation related to bloating and all these other quality of life issues, that may impact some decision making. Next slide. So So there's a lot of future things that we're looking at. We're looking at a lot more detail right now, and we're going to submit a publication hopefully within the next week, looking a little more detail at some of the dietary changes. Not only do we measure, no study ever has been able to get data like this as far as looking at not just can you eat or not, but also nutrients and things like that. We're going to be looking at quality of life and working with a team at Mayo Clinic, an alliance, looking at quality of life and qualities, et cetera. We're going to be looking at an evaluation of malignant bowel obstruction scale to be a better predictor. And we have a lot of information on actual operations. So can we get clues on best operations? And maybe one of the most important things is to complete this study, we had to do quite a few amendments to ensure that we completed accrual, including adding sites, Latin America being very important, making so we can have Spanish-only speakers, among many others. And we really think that this study and sort of formal analysis of what we had to do to complete it will really be helpful to the field. So with that, I am done.
Thanks, Dr. Krouse. We're going to wrap up, but let me ask you one quickie. In my experience as a former GI oncologist, it wasn't so much the patients and families that were always reluctant. A lot of times the surgeons just said, oh, it's not worth it on an end-stage patient. Do you hear any scuttlebutt or discussion among surgeons about the results of your trial? Are they any more willing to do the surgery?
Yeah, no, it's a really good point. And maybe, so you do a study and we're so proud of finishing it. Is it going to change any minds? And so, and really, you know, I'll give you our highest accruer was from UT Memphis. And until he really saw that a lot of his surgical patients were actually doing really well, was he really continue to go full force to put patients on. I think, and in fact, with one of my co-investigators, one of the things that we're really working on, and probably another next step, is truly how to implement, how to make people, surgeons, use the data better. Because you're absolutely right. There's bias within, and people have seen, you know, bad things happen, and so they are still reluctant. And yet the data is clear that for a lot of patients, it is the better option.
Fabulous answer, and thank you so much. So we'll wrap up. I think we saw a nice variety of trials today demonstrating our depth and breadth within SWOG. I want to, of course, thank our speakers, but I also want to thank our attendees. We had more than 400 of you. Please stay tuned because we will continue to do best of SWOGs in the future, and we'd love to have you. I hope everybody has a great rest of the week.